Good afternoon, everyone, and welcome to Families USA's COVID-19 webinar series. We're excited to have you join us for today's webinar on advancing health equity through telehealth interventions during COVID-19 and beyond. Next slide, please. So my name is Amber Hewitt. I am the Director of Health Equity at Families USA. I am joined by my colleague, Lee Taylor Penn. Lee is a Senior Policy Analyst at Families and is the lead author on the report that we will be discussing. We'd also like to acknowledge Emmett Ruff, Policy Analyst at Families, who co-authored the report. We have a few housekeeping notes before we get started. First, all lines will be muted, and if yours is not muted, if you could please mute your line during the webinar. After our final speaker, you will receive instructions from Nicole, our operator, on how to unmute your line to ask a question. We also encourage you to type out questions in the chat box. You can do that during the presentation, and we will review those when we get to the question and answer period. We will also be recording this webinar, and we'll share the recording and slides after the call. And lastly, if you could please complete the brief survey once we conclude, we greatly appreciate that. Next slide, please. So we are delighted to have two guest speakers today. We will share a little bit more about them once we get to their presentation. But you see we have Families USA, Dr. Kevin Fasella from the University of Rochester, and Dr. Stephen Waldron from the American Academy of Family Physicians. Next slide, please. So the webinar will follow the agenda that you see on your screen, starting with Lee Taylor Penn. But before we do that, we'll advance to our next slide and share a little bit more about the Center on Health Equity Action for System Transformation at Families USA. The center is the only national entity exclusively dedicated to the development and advancement of patient-centered health system transformation policies designed to reduce racial, ethnic, and geographic inequities. We focus on advancing equity while improving outcomes, increasing value, and lowering costs. We do this by catalyzing and coordinating action to develop and implement health equity-focused healthcare delivery and payment policies, and achieve impact by partnering with and supporting community leaders, health equity experts, and other stakeholders at the national, state, and local levels. The Evidence for Equity Initiative is one of several initiatives operating under the center. I will now turn it over to Lee to share more about the Evidence for Equity Initiative.
As many of you know, delivery system and payment transformation relies on evidence-based care as a way to achieve higher quality and more affordable care that results in better health outcomes. But the evidence base is incomplete and in some cases biased. At Families USA, we want to identify and promote representative and transparent evidence to help decision makers transform the health system in a way that advances health equity instead of making inequities worse. This is the focus of our Evidence for Equity initiative. As part of this initiative, Families USA has partnered with the Patient-Centered Outcomes Research Institute, known as PCORI, to translate the results of PCORI-funded studies into actionable and clear policy recommendations for state and national advocates and policymakers. So a little about our partner PCORI. In 2010, Congress created PCORI to advance the quality and relevance of evidence to inform healthcare decision-making centered on patients and subgroups. PCORI funds projects that conduct patient-centered outcomes research across a number of portfolios to inform the development and implementation of delivery and payment reform policies. These projects emphasize particular populations, including racial and ethnic minorities, low-income communities, women, older adults, those with multiple chronic conditions, and children. So over the past 2 years, we have been working with PCORI to release a series of reports that synthesize, translate, and disseminate research findings that are particularly relevant for addressing disparities and improving health equity. So you can see we have all of our reports and briefs listed here. Our first report, which was released in 2018, was an introductory brief that described how diverse, patient-centered outcomes research can improve the evidence base for advancing health equity. The second report, released in 2019, focused on asthma interventions and used the results from PCORI's portfolio of asthma research to make policy recommendations for addressing disparities in asthma-related health outcomes. The third series, on community health workers, included a report and 2 issue briefs and translated PCORI-funded research related to, in addition to CHWs, but also peer providers, into actionable policy recommendations. And in our latest report, we discussed telehealth's role in responding to the COVID-19 pandemic and provide state-level telehealth policy recommendations to improve health outcomes and ensure health equity during the crisis and beyond. And each of these papers on the slide are live linked. So once we send out the slides after the webinar, you can read more about these reports. So in our latest paper on telehealth, we talk about how the COVID-19 pandemic has changed patients' treatment needs and the ways they interact with the healthcare system. But it's also changed providers' care delivery structures as they adapt to new delivery methods to serve patients and stay financially solvent. Because of this, states are making major policy and regulatory changes to expand health systems' telehealth capabilities to meet the needs of patients and providers. The shift to telehealth has tremendous potential to help people who have historically lacked access to medical care, including people in rural communities and people in low-income, medically underserved areas. However, health advocates should not assume that provider use of telehealth during the pandemic, when there is little choice, will shift healthcare delivery permanently. States must take the necessary steps to make telehealth accessible to low-income people and to help providers make the transition to telehealth permanent. The continued provision of clinically appropriate telehealth services past the emergency period is especially important for residents of rural and frontier areas, people in communities disadvantaged by social and economic injustice, individuals with severe chronic conditions or disabilities, and those without reliable access to transportation. Evidence from PCORI and many other research studies supports the effectiveness of telehealth in meeting patients' treatment needs and addressing health inequities, particularly in the areas of chronic disease management, mental health care, and remote patient monitoring. So in this report, we use 3 PCORI studies as the foundation for state policy recommendations organized around 3 themes. Number 1, improving financing and implementation. Number 2, removing provider barriers. And number 3, improving patient access to telehealth services. While I won't be going through each of our individual policy recommendations in the presentation today, I do recommend that you take the time to read our short issue brief, which will be linked in the slide deck that we'll share after the webinar ends. Now I'll turn it back to our moderator, Amber, to introduce our first guest speaker.
Thank you, Lee. I'll now turn it over to Dr. Kevin Fasella. Dr. Fasella is a professor of family medicine and public health science at the University of Rochester. His research focuses on using implementation research to promote health equity within primary care. He has worked for more than 30 years as a family physician within federally qualified health centers. Dr. Fasella, I'll turn it over to you.
Thank you, and thank you so much for the opportunity to talk today. Next slide, please. So I'm going to focus on what would be the priority area number 3, which is access. And I've titled the talk, Building Bridges to Assist Patients in Crossing the Digital Health Divide. And this will cover work supported by PCORI as well as NIH institutes. Next slide, please. So what is the digital health divide? It really includes a wide and ever-expanding range of technology, including video conferencing now that's becoming very common during the COVID epidemic, messaging through electronic health record portals, automated texting, remote monitoring, and really a growing array of health apps and wearables that often can exchange information with the healthcare provider. And this movement has been growing, but has been certainly accelerated by the COVID epidemic. We now have more than 100 papers that show that patients who are older, who have less education, lower income, and from underrepresented minority groups are less likely to have access and or to use these digital health technologies. Next slide, please. The problem is that this digital health divide amplifies what Julian Hart had labeled the inverse care law, which meant that those who had the greatest need for health care often received the least amount of it. And so when we add in another factor, which is access to digital health technology, this can amplify or exaggerate existing healthcare disparities in access. I think most of you listening recognize that the digital health divide has a number of contributors, and these include knowledge, skills, confidence, attitudes towards use of this technology, and of course, importantly, access to devices and connectivity, broadband, Wi-Fi, and so on, that enable a person to be able to use the particular technology. The premise really of this talk is that without bridges to cross this divide, that the impact on health equity will likely be substantial. Next slide, please. Now, based on what I've said, I think it's easy to see that the digital divide really differs based on the individual. For some people, it means crossing a crack in a sidewalk. And to another person, an older person with less education who's never had exposure to the technology, it really seems like a gaping chasm that, you know, where they really feel like they just cannot cross by themselves. So the corresponding support that particular patients need for successful crossing is based on the size of the divide that they face, essentially based on the particular unique barriers that patient faces in needing to be able to access the digital health technology. And so failing to align the supporting bridge to the size of the divide will effectively mean that some people will be permanently stranded on the wrong side of that divide. Next slide, please. So what I'm going to talk about today is essentially a bridge that supports patients in crossing that divide. And this was done through a PCORI project called Get Ready and Empowered About Treatment, which was using a digital health technology and training to support people living with HIV in being able to assume greater responsibility for their own care and become active participants together with their providers. Next slide, please. Next slide, please. Did we skip a slide? Yes. So the project involved use of a personalized handheld electronic health record that we created that provided personalized evidence-based recommendations to the patient based on the information that they put in. And we recognize that it was going to require lots of training in order for patients to be able to effectively use it. So we used a community-based stakeholder engagement process that really lasted, it preceded more than 5 years before the project started, that involved actually 7 a.m. meetings between patients living with HIV, HIV physicians, and organizations that served people living with HIV. So they came and attended these meetings. It typically lasted 45, 50 minutes in the morning. And together we developed this project. The actual idea came from one of the patients themselves. And then we used what's called a user-centered design to refine the intervention and refine the training to make sure that it met the needs of the patient. User-centered design essentially provides a prototype the patient gets feedback, and then refines it further, and then provides further feedback from patients in an iterative way. We did a small pilot and then obtained funding from PCORI for a randomized controlled trial. Next slide, please. The trial enrolled 360 people living with HIV. We worked with the Clinical Directors Network for New York City, so we enrolled patients both in Rochester, New York, and in the New York City larger metropolitan area. And you can see the demographics of the participants here. We had very broad criteria and tried to maximize eligibility. And the patient demographics really resembled the demographics of people living with HIV in both Western New York as well as the New York City area. You can see average age was around 50, 60% male, 70% were African American or Latinx, and notably almost 70% lived on an income of $1,000 a month or less. 30% had no high school degree or GED, and another 30% had a GED or high school degree. Importantly, 25% had never used a computer or smartphone before, so people were really starting at the basic level. Next slide, please. So the structure of the training involved 6 weekly sessions, each lasting 90 minutes. They were group-based, typically with groups ranging anywhere from 6 to 10 participants. They're co-facilitated by a staff member, as well as 3 or 4 trained peers. The training was used the principles of adult learning. It's very hands-on and included work at home to bring back to the next session. Next slide, please. The content of the training went over all of the basics, really starting as if nobody in the class had ever put their hands on a device. And what we did for those who had more experience, we encouraged people to assist other members. And we found that was a really helpful way to go. We covered, in addition to the device basics, we covered Wi-Fi and how to minimize data usage. Many people didn't even have an email account, and how to do that, and how to recover passwords to the device and to the app. Next slide, please. We went over internet and high-quality healthcare sites and bookmarking so people could come back to them and find them easily. And then, of course, how to use the great app. And there were a number of steps for that, so that people felt comfortable in using it. They also help people download and use other selected health apps in a similar way. Next slide, please. The training processes really focused on 3 factors. One was making the training relevant to the desires and needs of the participants. And as I mentioned earlier, we used a community-based stakeholder approach including getting feedback at the end of the pilot from all the participants, making sure that we were really covering the topics and doing it in a way that met people's needs. We aim to make the sessions fun and to create cohesion. And we aimed for basic mastery. We wanted everybody, regardless of where they started, to be able to have a basic mastery of the device and have basic eHealth literacy, so to speak. We also actually provided devices. We used the iPod Touch, which is no longer in existence because we didn't want to get into the complicated issue of phone plans at that time. And we also provided food and snacks for people to encourage and make it a more fun experience. Next slide. Our primary outcome was the patient activation measure, and the patient activation measure has shown to project meaningful healthcare outcomes, including adherence to medication, reduced emergency department visits, and even reduced hospitalizations. What you see here is that people with very low scores for patient activation, in other words, they were not particularly activated in the bottom lines there, improved considerably when they were in the intervention group, and those are the two lines at the top. So in both cases, the control, they improved, but as you can see, the differences were much greater for those who received the training than those who were in the usual care group and didn't get the training until after the study was over. Next slide. Our second outcome was eHealth literacy. There is a validated scale for that called the eHealth. And we saw a similar result here. As again, you can see the top two lines refer to those who received the training. The bottom two lines were those who were in the control. And in this case, what we actually saw were that the patients who were minority, those who were Black and Latinx, actually showed bigger improvements than those who were non-Latinx white. So I only have 10 minutes here, and I think that almost wraps it up. Next slide, please. I want to acknowledge our collaborators who worked with us over almost, on many of them almost for a decade. As I mentioned, it was a true community-based participatory research approach, and those are some of the names of the people as well as the organizations, in particular the Clinical Directors Network, and then the participating sites that we worked with in Rochester and the New Jersey City area. Next slide. And I provided a brief bibliography here for those who want to learn more about the details of what we did, because the training could actually be replicated fairly easily by many different organizations. Next slide. And thank you for listening.
Thank you, Dr. Vasella. Thank you so much for sharing your research and your results. And we'll have time to ask questions after our next speaker, so we can go to our next slide. I am happy to introduce Dr. Stephen Waldron, who is the Vice President and Chief Medical Informatics Officer at the American Academy of Family Physicians. He is a nationally recognized expert in health information technology and has over 15 years of experience. Prior to joining AAFP, Dr. Waldron was a National Library of Medicine Medical Informatics postdoctoral fellow at the University of Missouri, Columbia, at which time Dr. Waldron earned a master's degree in medical informatics, and he was also a residency-trained family physician. So Dr. Waldron, I'll turn it over to you.
Well, thank you very much, and thanks for allowing me to talk with you guys today, and thanks for the really important report that you guys published late last week. And I'm going to focus my comments kind of on the first two priority areas, but I also want to make a couple of comments on the last one as well. But I think it's important to realize what happened during the pandemic, and I talk about it being kind of like a high G maneuver, because we just rapidly changed direction as it relates to telehealth. Before the pandemic, we had a little bit of telehealth, most of it being kind of standalone, direct-to-consumer telehealth, and it was growing, and we were seeing advancement of that. But with the pandemic, within a couple of weeks, we went from that couple percentage points of visits to many practices delivering all their care or the vast majority of their care via virtual visits. And I think we could be proud of the fact that we didn't kind of break apart and we didn't lose consciousness during that high G maneuver. But I think there's some real opportunities for us to now to take. Sorry, sometimes I have the word problems where I can't think of the word that I'm trying to say. But take. Anyway, look at ourselves and say, all right, how can we learn from what happened, and how can we do things better, not only the next time, but more importantly, kind of moving forward in the normal care, not during the next pandemic. And just to give you some numbers here, we talked with our members, and we did a survey of our members in early May, and at that time only 6% had not done a telehealth visit with their patients a week prior. You take that in the pre-pandemic world, that was about 15% that were doing telehealth-related activities, so that's a very big difference. And one of the things that we found that really made the transition was the changement of policies around payment and the regulatory environment that what type of services could be delivered. And I think that's a real look at one of the big problems we have currently in healthcare, of it being focused on this fee-for-service model as opposed to a value-based care model where the physician and the patient are able to make the best determination of what types of services would be best for the patient to deliver on their health. Otherwise, in a fee-for-service, somebody else is setting those rules, and you try to set the rules in a way that people don't fraud and cause abuse. And you're really restricted in what you can do. So we saw that once you change those payment policies and allowed people to be at home when they got telehealth visits, and that they started to pay for those visits for providers to provide those, we saw a rapid expansion of telehealth. And you saw a lot of people, both on the patient side and on the provider side, that showed a lot of satisfaction. So if you think about the way that was deployed over weeks, and the anxiety around the pandemic and just the changes people had to go through, and the uncertainty of how do you do these telehealth visits, how do you put them together, how does this work, will this work, is this the right technology? Think of that context, and still the vast majority of people were satisfied with the care being delivered via telehealth. We can't go back to a model where there's not telehealth moving forward. When you look at, though, some of patients weren't able to have the right technology. So either they did not have a smartphone or they didn't have connectivity, meaning they didn't have broadband access. And those are real challenges in regards to making sure that we have good health equity by using these telehealth visits. One thing that we found during the pandemic is that people were able to revert to regular telephone-based care. So we saw payment models that allowed for that to actually happen. As we think about some of the challenges on the barriers front, though, education become one of the biggest challenges for our docs to be able to understand how to do this and work with this really well inside the practice. But also patients were not understanding how to actually leverage this technology, and the previous speaker talked about a great program to really do that education. We also found that folks didn't understand the workflow inside the practice of how to actually integrate this with the usual source of care. Again, telehealth traditionally have been done as a standalone model and not done as part of the usual source of care. So we have those issues around making sure that we have good connectivity and continuity of care so that care can actually be coordinated. And that's really a big issue when you talk about folks that don't have education to be able to manage that by themselves. So the last thing I wanted to talk about, and I saw the slides just got moved to the next slide, is if you go back one slide though, sorry. So as it relates to the third priority that was in the report talking about the digital divide, I think it's important to understand the kind of the diffusion of technology. So technology will continue to evolve over time, and there's a natural progression of that if you think of individuals, there's some people that like change, that like new technology, and they gravitate toward that. Those are called the innovators. There's a next group called the early majority, and those folks that are able to understand and take more risk and are comfortable with taking risk, but they're not really doing it to adopt it for the technology, but they really see the promise of the technology and the product to be able to provide them value. You then have the late majority, which are individuals that really are not really savvy on technology, not really like technology, or really not interested in taking a lot of risk. But if the value proposition is there and they see other folks that have adopted technology, they are really actually able to adopt it, they'll adopt it. And then you have the last group, or the people that have a challenge of adopting the technology, and either the fact that they don't have an interest in technology or they have disparities that not allow them to adopt the technology like they would. So it's important to understand that that gap will continue as you think about that trend, that model of adoption, but we need to make sure that we continue to close that gap and shorten that gap up, especially as it relates to those individuals that are not adopting because of the the inequities in our current system. But I think what's really important is to really focus on what the real gap is, and that's the health gap, and that's what we can't tolerate. So while there still will be this digital gap, we need to make sure that there's not a health gap. And I think there's some real opportunities to leverage the technology to enable non-technology solutions to help eliminate some of those gaps. So I mentioned one at the very beginning of my comments around the telephone. So for those people that couldn't get connectivity or didn't have a smartphone, we're able to leverage the traditional telephone to be able to deliver technology-based solutions to them with a lower level of technology. I think there's also opportunities that if you're able to provide as a physician services to some individuals via telehealth, it opens up your schedule during the day to allow that access for people that don't have that type of access. So instead of waiting a month to see your physician, you could get in that same day or fit it in with your work schedule more appropriately for you, as opposed to, well, this is the only option that the provider has for you to be seen. So I think there's some ways that we can really lever that. In the last slide, I want to talk about kind of some of the things that we're trying to do at the AAFP as it relates to narrowing that digital divide and really closing that healthcare gap. The first is to really keep health equity at the forefront. We have a Center for Diversity and Health Equity, and we've engaged them as part of our work at the AAFP that we do in the health information technology front. I'm glad to see that Families USA is also working on trying to drive that forward as well. I think the second one is really focus on these 3 C's of continuity, coordinated, and comprehensive care, and make sure whatever technology solutions we think about that we really focus on, those are the real outcomes that we want. And how is the technology allowing access to happen, and doing it in a way even for those folks that don't have access to the technology. And I already mentioned the third bullet here of how you actually lever this technology to expand those resources to deliver non-digital services. So again, you make sure that you do not have a health gap, even if there is a digital gap in the folks that you take care of. And then lastly, I think is really important is to really invest in the payment models to support this, both from a physician standpoint but also from a patient standpoint, to adopt these technologies. And again, I talked about how fee-for-service model really doesn't allow that to happen. So if you have more of these value-based care models that now the patient and the physician are ones determining what's the best level of care. And it makes more sense now to say maybe I as a provider would start providing smartphones and connectivity to my patients that can't have access to that because of their socioeconomic status, just because we need to be able to close that health gap, and my payment model is associated with closing that health gap. So I really look forward to the conversation around in the Q&A section around how to close this gap, but also more importantly, how to make sure that we close that health gap with these new payment models and removing barriers to telehealth, both for providers and for patients. So thank you.
Thank you so much. And just to encourage everyone participating in the webinar to write in your questions on the chat box if you would like. And in a minute, we will open up the line, but I do want to kick us off with one question to all three speakers and borrowing what Dr. Waldron mentioned around the high G maneuver and how we transition from almost no telehealth visits to almost all telehealth visits in many practices. So my question to the three presenters is, what telehealth advancements or policy changes do you want to see continued post the National Emergency Declaration in the context of health equity? So I'll whichever panelist wants to take that first.
Steve, I'd be happy to take a first crack at that. I think one of the most important ones is the expansion of what's called the originating site. So for those that are not in the policy wonk space, originating site is where the patient is located at the time that the service is delivered. And in the pandemic, that is now to be able to be the patient's home or an area like the patient's home if they either don't have a home or they're at work and they have a secure place that they can have that care be delivered. And I think that's really important if we want to be able to provide these type of services for folks, especially if they don't have transportation capabilities. They have disabilities that make it difficult for them to travel. So in the old world of telehealth, you still had to travel to a healthcare provider to get telehealth services from another provider that was at another location. So I would say that's probably one of the most important ones, and I think the second one is continue to keep the payment for these type of services until we make that transition to value-based care delivery.
Yeah, I would agree with Dr. Waldron. Certainly, both of those are vital, and without the payment, rates of use of telehealth will drop back down. In addition to being a family physician, I also do addiction medicine, and there's been some waivers in there that have improved access to people for medication-assisted treatment for opioid use disorder that can improve access, for example, by allowing people to be initiated on treatment through telehealth and following people through telehealth. So I also think that the mental health counseling telehealth also opens up a whole nother realm for people who have had limited access to mental health because perhaps due to geography they may live in a rural area and may have very poor access. And again, telehealth either through phone or through video chat makes that accessible.
Thank you. And Lee, did you have a response to that question?
Yeah, this is Lee, and I would just add on that one thing we've seen that's been really valuable in terms of expanded flexibilities with telehealth right now is reimbursement for audio-only telehealth interactions. And I know that this was mentioned earlier by Dr. Waldron, I believe, but there are a lot of people who don't have access to video conferencing technology, so being able to take a telehealth appointment with your provider just over the phone is really important to improving access, especially for low-income patients. And so that's something that would be great to continue to see past the emergency period.
Thank you, Lee. And I think that touches on a couple of the questions we had in the chat box. But I think, Dr. Waldron, were you going to chime in for another comment?
Oh, yeah, sorry. Yeah, I just, when Dr. Fazell talked about the rule, again, just make sure there's no geographic restrictions, because, again, it was really focused on rural and frontier areas, where we know in our inner cities they still have the same issues around transportation and getting to a practice location, even if it's only, 4 or 5 miles away. If you don't have any public transportation and no car or anything, that's still a very difficult situation. So I was going to add that one to the mix as well.
Thank you. And I just realized there was a comment earlier in the chat that I did not I thought it was responding to everyone. I just want to acknowledge Barbara Kornblau, who represents Family USA, who represents Disability Health Coalition advocates on the Health Equity Task Force for Families USA. So definitely thank you for raising what you mentioned around the impact on disability inequities. I believe in my opening remarks I didn't do our center justice. We're definitely grateful for Barbara's advocacy, and our center focuses on Center on Health Equity Action focuses on disability inequities and other equities beyond race, ethnicity, and geography, in addition to taking an intersectional approach with the understanding that multiple systems of oppression, such as racism, ableism, and classism, based on a person's social identities, has an impact on health and healthcare. So, Barbara, thank you for raising that point. So I see a couple more comments in the chat box, and I'll turn to Ruth's comment. So Ruth asked, who are you suggesting would pay for smartphones or broadband for patients who don't have access? And Lee, I'll turn to you first for that question.
So we've seen that there are some states, and we write about this in our paper, there are some states who have used Medicaid Attendance K authority to provide technology like computers and tablets and care coordination support in conjunction with utilization of telehealth tools. So that is something that, some states are doing. Like, for example, Kansas has used the Attendance K authority to provide monitoring equipment and training to patients with chronic diseases. And New Mexico has offered specific Medicaid patients up to $500 to help purchase devices that allow for remote video conferencing, training, and monitoring by clinicians. But this is definitely something that we would like to see expand and see other states that are doing this as well, because this is a major issue, and we definitely need, our paper is focused at the state level, but federally we really do need investment in broadband to make sure that, even people who do have the ability to purchase these devices actually have the connectivity that they need to be able to engage in telehealth as well.
Yeah, I'll just chime in. I think that's a really important point. In New York State, low-income people have access to relatively low-cost smartphones through the federal Lifeline program. But the big issue is the cost of plans and exceeding the data and minutes, and so then people get cut off. And as a family physician, I can't get a hold of people until they get enough minutes to reactivate their phone, and that's a huge problem.
Thank you for that. And
Steve, I think connectivity.
Oh, go ahead. Sorry. Go ahead.
Oh, sorry. I was going to say I just see connectivity as kind of like utility companies of having phone access and having power to your house. Without it, you can't participate fully in a lot of things other than just healthcare, but even just the economy. So it's even bigger than just a healthcare inequity issue.
Great, thank you. And I see other comments in the chat box, but Nicole, to switch things up a bit, I'm wondering if there are any questions on the phone that we can turn to before going back to the chat questions.
Ladies and gentlemen, if you'd like to ask a question over the phone, please press star and then 1 at this time. And you will hear a voice prompt letting you know when your line has been opened so that you can introduce yourself before posing your question. Again, that is star and then 1 if you'd like to ask a question over the phone.
Well, this is Amber. I will jump back in since we have some great questions still in the chat box, but we can open it back up later if that would be helpful. I see a question from Summer that I think is a really important one to pose to the group. So Summer asked, what are examples of addressing non-English speaking populations and the need for interpreters?
This is a huge problem that really, I think, ultimately needs a federal response. Right now under the law, providers are required to provide that and pick up the cost, which then creates a perverse incentive for practices not seeing patients who don't speak English or maybe are use ASL. This really requires probably a federal guidance, and ultimately perhaps should be borne by the healthcare plans providing this and taking it over so that everybody is guaranteed to have ideally in-person interpretation, which is often better, but at a minimal, digital. But it remains a huge access barrier in the United States.
Steve, I just would add, though, that I think that's one of the big promises of technology. We're seeing some of the new machine learning, natural language processing things that are able to do that kind of real-time translation. And then also with telehealth, being able to add another individual into the virtual visit, no matter where that person is, to provide those translation services is another promise of the technology. It's just not been implemented very well. And as Dr. Pacel's talked about, there's some business model problems with our current situation as well.
Yeah, and this is Lee. I just wanted to say really quickly that there are only a limited number of states that directly reimburse providers for language services. And so one thing that I think would encourage more language interpretation services, especially when it comes to telehealth, is direct reimbursement to these providers to secure telehealth platforms that allow for integrated language interpretation services.
And I would add that the reimbursement really needs to be adequate. It needs to really cover the cost of the full cost of those services provided, if you really want, a wide swath of physicians to participate.
Thank you. And I see a question from Caroline that I think is also important, given many of you may know that Families USA, we do a lot of advocacy around the community-based workforce, particularly community health workers. Caroline mentions promotoras. And her question is, how can we ensure community health workers and promotoras are considered as part of payment models around telehealth? And I will flag, related to this question, but not specifically answering Caroline's question, that Emmett Ruff, who's a co-author on this paper, telehealth paper, released a paper on how states are integrating CHWs into their Medicaid programs. But Lee, I know you have some thoughts on this question. Oh, actually, Dr. Pacel, I'll turn to you. And I can repeat the question. How can we ensure community health workers are considered as part of the payment model?
Well, that's really the purpose part. Again, that gets at state and federal policy regarding coverage of community health workers. They're certainly an invaluable member of the team, And as we showed as part of the GREAT project, they can become, with appropriate training, they can provide the support needed to teach people how to effectively use that technology. So yeah, I think they're indispensable, but the problem right now is really, again, with that business model from the fee-for-service system and coverage, which differs widely by states.
Any other thoughts on that question? So Nicole, we can try to turn it to the phones one more time. And while you're doing that, I'm going to review the questions in the chat box.
Okay, once again, ladies and gentlemen, it is star and then 1 if you would like to ask a question at this time. And it appears we do not have any questions at the moment.
Okay, thanks for checking, Nicole. I am pasting in the chat box a link to the Community Health Worker report in case you are interested. And I think we have time for one more question. Let's see. So Jason asked, what do we know about the safety and effectiveness and satisfaction regarding establishing care by audiovisual or telephone-only connections? So thinking about a new provider-patient relationship, especially that telephone, especially patients who have limited access to audiovisual connections. So Dr. Waldron, Dr. Vasella, I don't know if you have thoughts on that question as providers, speaking to the safety, effectiveness, and satisfaction regarding establishing care, say a new provider-patient relationship via telehealth.
Yeah, this is Stephen. I mean, I think you saved the hardest question for the last. I think that's a great question. I think it's one that we need to make sure of. And I think for all the ways that we look to expand and move telehealth forward, and make sure that it's safe, it's equitable, and that we have good evidence for what we're doing. But I think we also need to make sure that we allow for some, some advancement so that we don't have to have all the evidence, randomized controlled trials before we move things forward. But I think the issue there is really kind of what's the standard of care. So I think it depends upon what service that you need to have as an individual patient. What do you plan to engage with that provider on a longer term sense? So, say for example, you're coming in, you have headaches, and you're wanting to get evaluated for headaches. You just new to a new town, and you want to establish care, and you want to do it via telehealth to get things kicked off. That's probably appropriate. Now, if you're saying, I need something and I just want a one time with a remote practitioner, and I don't plan any follow-up whatsoever, and I don't have ability to go see them afterwards or get access to my record afterwards, then it may not be as safe. So I think, unfortunately, it really depends upon the interaction and what the need is of the individual patient, because I don't think we want to limit people's access to kind of starting to establish care via telehealth. But at the same token, there's really some issues around safety and fraud and abuse if we allow for establishment of care via telemedicine only.
Really great points. Dr. Pasella, anything from you before we close on that question?
The only additional points I would add, because I agree with everything Dr. Waldron said, is that when you use these modalities, you have less access to cues. Phone, you have no visual cues, and video conferencing is not quite the same in terms of being face to face. And so I agree that at this point we don't know exactly what the trade-offs would be for a new patient needing a provider based on those three different modalities. If I had to guess, I would say it probably depends on the patient and the provider and the concern, as Dr. Walden said.
Thank you. So I want to point you to the report. So we will make sure, if you haven't seen this, when we send out the recording of this webinar, to share the report with you. You'll also see in the PowerPoint slides, once you're able to click on the link, we have a Health Equity Action for Transformation Network. And this is not only just a listserv that you can sign up for to receive resources, but we're in the process of revamping this network to really serve as a health equity learning collaborative. So we invite you to join that network. And again, just thank you again to Pecori, Dr. Waldron, Dr. Fasella, and our lead author on the report, Lee Taylor Penn, and Emmett Ruff, who co-authored the report. The next slide shows our contact information. I know we weren't able to get to all of the slides on the call, all of the questions on the call, so I really appreciate everyone's active engagement in the chat box. Thank you for your interest and advocacy around health equity. So thank you and enjoy the rest of your afternoon.